Hello and welcome. Extrapulmonary manifestation. That's the term that describes the effect COVID-19 is having on the body beyond the lungs and respiratory tract that we've broadly known about. While these symptoms and conditions beyond the lung have been observed by doctors we've been interviewing over the last 3 months or so, perhaps for the first time, we have a comprehensive study on this subject on how many organs beyond the lung are being affected in the body. Now, this study has been led by Dr. Aakriti Gupta, Interventional Cardiology Fellow at Columbia University, New York, and Dr. Donald Landry, MD and PhD Chair of Medicine at Columbia University Vagelos College of Physicians and Surgeons, along with Dr. Mahesh Madhavan, Fellow and Clinical Researcher in Cardiology at Columbia, and Dr. Kartik Sehgal, a Hematology and Oncology Fellow at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston. Thank you all for joining me. So, Aakriti, do you want to quickly take us through what this project has meant in terms of size and scope before you've arrived at the conclusions that you did?
Absolutely. So we were at the epicenter of this pandemic in March at Columbia University in New York City. And very quickly, our ICUs were overflowing with COVID-19 patients. And even though I was a cardiology fellow, that became the primary responsibility to take care of COVID patients. And very quickly, we started realizing that it's much more than a lung disease. We were experiencing very high rates of kidney failure, high rates of stroke, heart attacks, a lot of blood clots that were forming everywhere. We were changing their catheters very frequently. So all of that was a little surprising because we had not heard a lot about that in March. And that led us to undertake this massive effort where we, had a lot of different interdisciplinary physicians come together, dig the literature and take insights from our clinical experience at the forefront to put together this paper so that we could share our experiences with a broad audience globally.
Right. Mahesh, could you take us through what the study has found chiefly? I know that you've discovered how there are other parts of the body, I mean, the kidney, heart, brain, gastrointestinal, and these are some of the things that we've heard of here talking to frontline doctors as well. But tell us how you've seen it and what are the kind of statistical insights?
Sure. Thanks for having us again. Really appreciate it. As Aakriti mentioned, kind of seeing these patients firsthand in front of us and having all of us trained in internal medicine, we're all kind of attuned to appreciating how the various organ systems were affected by this virus. And, we had collectively done some previous work in this space prior to doing this specific review. And so we were, again, highly aware of the potential for this virus to have a number of manifestations. So we looked through all the literature available. We went through over 1,000 articles as part of this process. The articles were kind of published all throughout the world. China was obviously the first to be affected by this virus, and then Italy and other countries across the globe. We went through the literature extensively. We kind of organized them by organ system from the top down, from the neurologic and nervous system to the heart to the lungs, the gastrointestinal system. Hematologic abnormalities and manifestations are quite prevalent as well. And we kind of grouped them as follows. We grouped the manifestations that were present, and we kind of summarized the purported pathophysiologic mechanisms for these manifestations. And based on our individual experiences, along with a number of co-authors with expertise across the gamut of internal medicine and neurology, we're able to kind of summarize our own kind of experiences from a firsthand perspective. And we're able to, in some ways, provide guidance as to how patients should be potentially triaged and treated for these various manifestations. And so kind of finally, we're able to kind of show some of the things that kind of are yet to be unanswered in areas that require further exploration as kind of future research endeavors need to follow.
Right. And so what would be the highlights if you were to say that here are the top four, let's say, symptoms or set of symptoms which are different or new compared to what we maybe saw in the first month maybe of COVID-19?
Yeah, I think the main thing that we're able to kind of come out of this and say is that the virus has a number of direct and indirect effects. The direct effects, there is some evidence that viral particles are found in a number of organ systems. That has been shown on biopsy and autopsy specimens in a number of series. But the indirect effects, I think, are the ones that are causing kind of significant consequences as well. In the setting of profound inflammation and instability in the setting of serious viral infections, and those are ones where patients often require intensive care unit stay, mechanical ventilation, and requiring, being connected to the ventilator for extended periods of time. This inflammatory milieu and inflammatory response can result in a number of issues. So firstly, I think one of the most common things that we're seeing, at least anecdotally, and in looking at the autopsy series and looking at the clinical series, is the number of clots that patients have. So we're seeing clots in large vessels. So if you scan the person's legs, or if you do a CT scan to evaluate for clots, we're seeing that pulmonary embolism and deep venous thrombosis are very common. There are series that have systematically screened patients, meaning they've scanned at least once or twice upon admission into the ICU. And rates can exceed 60, 70% and up to 85% in some series of clots. And that is kind of an extremely surprising and elevated number that I don't think we've necessarily expected to be that high. As cardiologists, we're attuned to cardiovascular, obviously, manifestations. And there are a number of series that demonstrate the rates of myocardial injury that is evidenced by elevated cardiac biomarkers. It's quite significant. And when patients have that, they're more likely to do poorly. So there's evidence out of our hospital, evidence out of Mount Sinai, other institutions across the country that suggest if you have myocardial injury, you're more likely to require intensive care unit stay. You're more likely to do poorly and potentially die from this viral infection. And then, the renal manifestations are very common. We see patients fairly frequently requiring renal replacement therapy. Our hospital, there was a series out of our pulmonary critical care group that demonstrated that rates could exceed 30% if you're in the ICU. The need for renal replacement therapy is pretty common, at least 30% in our internal cohort. And then there are a number of other kind of manifestations that we have described kind of pretty extensively that suggest that this virus has, unfortunately, systemic consequences. And I think Kartik might weigh in there as well.
Right. So, Kartik, why? I mean, so obviously we know that this is a deadlier disease than maybe what we started out with. But why is this happening? I mean, what is this? This is SARS. It was supposed to be a severe acute respiratory syndrome and a version of that, or a deadlier version of that. But clearly now it's much more and beyond. So how do we, or what do we know more about the behavior of this virus?
So absolutely. So one of the first things that we have to realize that we are still early on in the pandemic, though it feels like a lifetime for sure. But in terms of science, scientists are still working at an unprecedented scale to find out what might be special or unique about this virus, which may be bringing on all of its manifestations that we've had the chance to review. Things that we have kind of looked into the literature and based upon experience with other coronaviruses, such as the one which caused the SARS epidemic of 2003. And we were able to kind of use the science which was discovered during that time. And we propose 4 different ways in which the virus can affect the body and may be responsible for all its systemic effects. So 2 of them may be unique to the virus. One of them being its entry into different kind of body parts through the receptor that has ACE2. And there is evidence in the literature that ACE2 and some of the other receptors that are required by the virus to enter and attack the cell can be present in the heart, can be present in the kidneys, can be present in the gut, which may cause this. And the second way which is linked to this ACE2 is the RAS pathway, which is generally responsible for maintaining the blood pressure, fluid, and electrolytes in the body, and that may be modulated. But again, all of this needs to be investigated a little bit more. The second part, which may not be unique to this virus, is whenever an infection happens, be it with a virus or bacteria, the immune system gets activated, and it's a normally protective mechanism of the body to fight against the infection. But sometimes some of the infections, and this virus particularly, may come up with ways to hijack the system and lead to a very severe inflammatory response, which can then lead to clotting abnormalities as well, and a dysregulated immune response, which can then go haywire and affect all the body parts.
Right. Aakriti, can I come back to you? So, one question, since I am sitting in India, is are you getting a sense that all these findings that you have today would be universally applicable?
Yeah, for sure. I've been very closely following the situation in India, and my colleagues in the hospitals in Delhi and Mumbai universally are reporting very similar presentations as what we saw in our intensive care units. So yes, and particularly, I think in any population that has higher proportions of either high blood pressure or diabetes or obesity, metabolic syndrome, those populations are going to be much more vulnerable to the serious effects of the virus. And I think India fits that bill, unfortunately.
Right, and in your treatment response, how has that changed because of this? As you found that, let's say, and we've seen this, I mean, doctors responding to the same question in India as well, that the number of drugs you're administering now to cure or try to cure is changing, or the cocktail of drugs is evolving constantly. So where does it stand today for you?
Yeah, so during the course of treating these patients in the last 3 to 4 months, I think a lot of things have changed, and I can give you an overview of that. For example, in the beginning, there was a lot of emphasis on preemptively intubating these patients, even if they haven't reached the threshold that we normally would use, because the thought was that it helps. But we realized that it probably doesn't help to preemptively intubate. So now we actually wait and avoid putting the breathing tube in these patients still as long as we can. Secondly, when we were putting the tube in, then in the beginning, we would give very high pressures into the lungs because the thought was that these lungs are going to benefit more from higher pressures. But then we realized that that's not true, because they were the lungs would burst open sometimes and caused air to accumulate in the chest cavity, which is not good. So that has changed, and we don't do that anymore. There's something that's called awake proning. So normally we would prone the patients only when they had a breathing tube in them. And that was thought to be helpful, which it still is. But now, even without putting the tube in, we can prone them. That is, they lie on their stomach, and that actually helps them to breathe better. These are all practices that evolved in the first 2-3 months of taking care of these patients, and we have gotten so much better in doing that. Secondly, there's the steroid study that came out of the UK. So before, we were actually reserving our steroids only for the really last-ditch effort when the patient's really sick and may not survive. But now it's become a routine practice that these patients are getting steroids when they're going into the ICU and getting critically ill. Right. And I think there are also efforts now to think about that as soon as they get hospitalized. And then I'm sure you're aware of the hydroxychloroquine studies. In the beginning, everyone would get them when they get hospitalized. We're not doing that anymore based on a lot of evidence that has come out. So those are some of the practices that evolved. And the other thing is in terms of extrapulmonary manifestations, because now we are more aware of all of these systems that can get involved. We have a series of what we call COVID labs, which is a lot of different laboratory tests that we perform in patients as soon as we know that they're actually COVID positive. And that would uniformly screen for injury to the lungs, the kidneys, the heart, particularly the kidneys, because we check the urine for proteins. Right. So we have a lot of information now that we act upon with much more anticipation than we did before.
Right. So, Mahesh, for those doctors who are reading or will read your study or listen to this conversation, what are the key things that you would be telling them, or the study would be telling them, which may cause some shift in strategy in response to patients and severe patients?
Yeah, that's a great question. I think based on the experiences that we have had up front, we can only inform future physicians treating future patients as to how best they might be able to respond to the patient in front of them. So the hope is that they don't necessarily have to reinvent the wheel from where we were several months ago. And the hope is that this can lead to protocols that individual hospitals can put in place for the patients in front of them based on some of the things that we saw and based on their own experiences. So, for example, Aakriti mentioned in terms of laboratory assessment. In some ways, this kind of lends to the practice that if you have the patient in front of you, you should regularly check the labs relating to the kidney, potentially relating to the coagulation system in the heart, depending on the specific patient. So the hope is that we're able to kind of give strategies for physicians to treat the patient best in front of them. And additionally, as kind of this evolves over the next subsequent weeks to months, the hope is that additional research will be performed. There are obviously a number of ongoing trials that are going to study a number of questions relating to some of the things that we brought up in the paper. And hopefully that will also lend towards better treatments, as you're kind of suggesting that, treatments have certainly evolved even in such a short period of time in terms of both best practices on the floor in ICU and specific targeted medicines for COVID itself.
Right. Last couple of questions. Kartik, as you look ahead, what are the things that you take encouragement from, and what are the things that you're still, let's say, concerned about and worried about in when it comes to the bottom line, which is really saving more lives and keeping people healthy?
Absolutely. So I think what I have been pleasantly surprised with is how the world has come together to fight this virus. I think scientists all over the world are collaborating. And we have seen that when we work together, we build together. I think doing randomized clinical trials as a whole nation or as even the whole world is an idea that we should all strive for, to be able to answer questions more quickly, to be able to help our patients better. And I think that is something which has been pleasantly surprising and really encouraging for all of us. The thing that I think is still unanswered is how this virus is essentially hijacking the immune system, and how can we do better in terms of fighting this. And also a couple of questions about the clotting disorders, as I am a hematologist by training. So I think the big question that I think hopefully will be or hopefully is answered in the near future is the question about giving these patients full dose blood thinning medicines or anticoagulation. And that's an area that I'm particularly invested in. And I know my colleagues at Columbia, Dr. Gupta, Dr. Madhavan, and their colleagues at Columbia are working towards answering that question through a randomized clinical trial.
Right. Mahesh, what are you looking out for or looking ahead to?
Yeah, I'm really hoping that we can come up with treatments that are going to be effective. We have seen in recent weeks that there are some strategies that seem to have some benefit. Dr. Gupta mentioned the steroid story that came out of the recovery trial, and we're hoping that will lead to better outcomes. There are some other studies, such as the remdesivir story, that might potentially reduce the length of stay of patients in the intensive care unit. So although that doesn't, at least as far as we can tell, have a mortality benefit, obviously shortening length of stay in an intensive care unit is an important thing that we can hope to achieve, especially as resources are tight in the setting of so many patients being admitted. I think the thing I'm looking forward to, and the thing that we all want to see, is obviously a vaccine to prevent further patients from getting sick from this. And I know there are a number of efforts all across the globe, including India itself, to help with that. And there are also potential strategies where you can potentially purify antibodies from patients with, who have recovered from COVID, that are also being studied. And hopefully that can potentially be used as either a primary or secondary prophylactic strategy to help patients, from getting really sick from this virus. So I'm really hopeful that ideally over the next several months, we'll have made even further headway, and hopefully things will start getting better as we approach next year. But again, this is just hope, and it requires a lot of work and a lot of effort all over the world. So we're really crossing our fingers that we can continue to make strides.
Right. Aakriti, last question to you. So, going by the patients that you've seen, and particularly in those difficult months that you talked about, what is your advice to, people? Yes, we have to mask up. Yes, we have to sanitize. Yes, we have to social distance. But I'm sure it goes beyond that, particularly for those who are more vulnerable. Your advice and insights.
So my insights for particularly patients who end up getting so sick that they're hospitalized would be to think about this disease as much more than something that finishes at the time of discharge. So COVID care does not end at the time of discharge. I think as a society, as physicians across the world, we have hospital systems. We all have to think about how we facilitate post-COVID care, because a lot of these patients are sustaining multiple organ damage that that they may recover enough to get discharged, but are still not at a place where they don't get seen as an outpatient and get follow-up. For example, like doctors Sehgal and Madhavan mentioned, for all of these people who get blood clots, particularly in their lungs, they're now going to be on blood thinners for a long time. And that is something that needs to be followed up very closely as an outpatient. There are a lot of people who will suffer damage to the muscle of the heart or damage to the kidneys, and they would require dialysis for a much more prolonged time now. So we need to have systems in place to be able to take care of these patients. And I realize we're so overwhelmed right now just taking care of patients who are hospitalized, but we do need to think of where these patients transition to at the time of discharge. And even if they go home, then how are we going to make sure that they can have meaningful, healthy lives moving forward?
Right. Dr. Gupta, Dr. Madhavan, and Dr. Sehgal, thank you very much for joining me, sharing your thoughts. And I do wish you and your colleagues and teams all the very best in this fight against this deadly disease. Thank you very much.
Thanks so much for the opportunity to be on this. Thank you.
Great meeting.